And now with this, we come to the next speaker, Dr. Vijay Shetty, a prolific surgeon, a great clinician, and a great phaco teacher. It's my privilege and honor to present him to you, who's going to speak on newer presbyopic IOLs. Vijay. Mike.
Good afternoon, everyone. At the outset, I would like to thank Dr. Haldipurkar sir and AIOC Scientific Committee for giving me an opportunity to be a part of this IC. See, my topic for the day is newer presbyopic IOLs. So, the modern lifestyle requires us to use, to work at various working distances. So, correction of presbyopia following cataract surgery with conventional IOLs needs us to use bifocals or progressive lenses, which itself has its own set of problems. So there are certain options for presbyopic corrections during cataract surgery, which includes monovision using a monofocal lenses, or like we could use multifocal lenses, or we could use EDOF lenses. The multifocal lenses is mostly the diffractive or diffractive-refractive lenses, which could be either bifocal or trifocal or quadrifocal technology. EDOF technology could be of various varied technology, including wavefront, which includes elongation of wavefront, and the second is by using spherical aberration, and the third one is a refractive IOL, wherein a near ad is put in the lower segment of the IOL, and we could have a pinhole which cuts off the paraxial rays and gives a depth of field. And finally, a hybrid lens, which I mean here is a use of diffractive optics to create an EDOF lens. So technology used in multifocal IOLs are mainly diffractive gratings. These gratings, actually the properties of these gratings like step width and step height are used to modify the properties of the multifocal IOL. The narrower the steps give a higher ad power, and by reducing the step height, more light is given to the distance. This is used in case of apodization by shortening the height for peripheral diffractive gratings. Again, by changing the blaze angle of the diffractive gratings, you can create higher order diffraction, which is used in certain EDOF lenses like symphony lenses. The most recent multifocal technology or diffractive technology is trifocal IOL. Here a combination of two diffractive gratings with two different ads are given so as to get a trifocal IOL. And finally, a quadrifocal technology, wherein instead of 3 foci, there are 4 foci, out of which the one foci that is at 120 centimeter is the height of these gratings are shortened to deviate this light to the distance. So distance gets more light and hence there is less dysphotopsia. At the same time, the intermediate distance is 60 centimeter instead of 80 centimeter. This is used in Alcon panoptics lenses. Unlike multifocal lenses, EDOF IOLs have multiple technologies which are used. IOLs with certain attributes are defined by AO task force as EDOF lenses. So, for an IOL to be called an EDOF, these attributes should be checked in monocular conditions. The mean distance corrected visual acuity should be comparable to the monofocal lenses. The defocus curve should be at least minus 0.5 diopter greater than the defocus curve for a monofocal lens for 20 by 32 vision. So this is, the blue line shows a defocus curve at 0.2 visual acuity, that is 2032, there is an additional depth of focus of 0.5 diopters. Distance corrected intermediate visual acuity, and that is done at photopic condition at 66 centimeter at 6 months, should be superior to the monofocal IOLs with a p-value less than 0.025. At least 50% of the patients implanted with EDOF lenses should have distance corrected intermediate visual acuity of 0.2 logmar units, which or better at 6 months. And the way the visual acuity is checked is also standardized, that like the the chart should have a illumination of 85 candelas per meter square. The defocus curve should be, the way the defocus curve should be done between 1.5 to 2.5 diopter is in a gap of, in a step of 0.5 diopters, and between plus 0.5 and minus 0.5, it should be checked in 0.25 diopters. The defocus curve should be stratified according to the patient's pupil size and axial length. So all kinds of eyes should be included when you are assessing a EDOF lens. The mesopic contrastic sensitivity should be performed at 1.5, 3, and 6 and 12 cycles per degree contrast. The EDOF lenses currently used are either wavefront based. Here there is an elongation of wavefront which is used in Vivity lenses, and there is an alternate positive and spherical aberration which is induced, which is used in case of mini-well lenses. And there is a refractive lens wherein a simple refractive element is added on the lower portion of the optics. And pinhole lenses are also used for increasing the depth of field. And finally, a hybrid lens. I'll come to each one of these. There can be various strategies used along with EDOF to get better binocular vision, which includes micromonovision and mix and match. That is, two different kind of IOLs are used in each eye. Coming to mechanism of action of refractive IOLs, Oculentis Comfort is the lens which is used. This is a rotationally asymmetric refractive bifocal IOL. That means like it has to be placed in a certain orientation only. Lentis Comfort is the most popular refractive EDOF lens. The IOL orientation in the bag is crucial for successful outcome. Haptic with a single notch has to be placed in the proximal end of the cartridge when you are loading, and it has to be rotated either clockwise or anti-clockwise depending on which eye you are operating. And finally, the one with a single notch has to be placed superiorly so that the near segment is down. However, this Lentis Comfort was only able to give good intermediate vision but not good near vision. So there was an improvement over this lens. So then the evolution of M plus lens came into picture. So they started with M plus 2 with an addition of plus 2, and M plus 30 which had an addition of plus 3. However, this also had its own problems. So finally came the M plus X lenses. These had special features like surface design optimization with central extended near vision segment for pupil independence. That was that near segment came a little higher up in the periphery so that even in a small pupil it works well. And the small lens slit was used, that is around 0.7 millimeter instead of 1.15 millimeter in Lentis Comfort. And finally, an additive paraxial asphericity, which improves the depth of field and simplifies neuronal image interpretation. Although there is no intermediate focus with M+, there is a focal area that extends depth of focus. Combination of Lentis Comfort and M+ gives a continuous binocular range of vision, so giving rise to a continuous range of vision. M+ lens may induce vertical coma and trefoil in dilated pupil because of a large near ad, so it can cause angel wing halos as well. So then the next lens is the mini-well lenses. This works on the principle of alternate positive spherical aberration and negative spherical aberration. Here there are three zones. The central zone has a positive spherical aberration, paracentral zone has a negative spherical aberration, and peripheral has an aspheric zone. The zone 1 and 2 gives an extended focus which allows good intermediate vision. However, this lens also had the same problem that it gives you a good intermediate vision but only a fair near vision. So mini-well Proxa came in. Here instead of 3 zones, there are multiple zones of targeted spherical aberration are created to induce, to give a good near vision. So this allows a range of vision extending up to 33 centimeters or 3 diopters addition. So when implanted with Minivel and Minivel Proxa, the blue line shows that blue line in the defocus curve shows that the vision is maintained throughout all the distances. So the binocular vision is good when you use Minivel and Minivel Proxa in each eye. If you look at the photic phenomena, it is Minivel is comparable with the monofocal lenses and is definitely better than Symphony and Panoptix lenses. Coming to the most talked about EDOF lenses, that is Vivity lens. Vivity lens has got a separate mechanism of action. This uses X-wave technology, wherein there is a modification in the central 2.2 millimeter zone. It has two smooth surface transition regime elements. The first one is slightly elevated, around 1 micron's elevation. It's a smooth plateau, and it has also a second element, which is a slight curvature change. Both these elements put together gives a depth of field. So if you look at a presbyopic IOL, a presbyopic condition, near light is focused behind the retina with minimal depth of focus. When patient is implanted with Vivity lenses, the central optics, the first transition zone helps in elongating the zone of forward, elongates the zone, and the second transition zone pushes it forward. So both the zones together gives a good depth of field, and that means good near vision and intermediate vision. If you look at if you compare Vivity with Panoptix, the near, intermediate and distance vision are comparable, although near vision is slightly better with Panoptix. However, if you compare the photic phenomena, the Vivity has got a much better profile in terms of halos and glare. Coming to hybrid EDOF lenses, that is wherein a diffractive element is used. Mostly it's used in Symphony and Synergy lenses. Here, the diffractive elements are modified in such a way that it gives a continuous focus or an elongated focus. However, certain limitations of the diffractive lens remain with such kind of EDOFs. With so many lenses available, choosing the right presbyopic correcting IOL is difficult. So we'll have to look at the patient requirement, patient expectation, affordability, and the eye characteristics. So identifying the patient's requirements and expectation includes to knowing about their routine activity and working distance for reading, driving after evening, current refractive status. Does he consider the need of glasses as a failure of the procedure, or are some halos acceptable? So when you ask the patient if the patient considers need for reading glasses as considered as a failure, or habitually reads at a closer distance and needs to read at a lower illumination, then consider multifocal IOLs with a higher AD. If the patient requires to frequently drive after it becomes dark, or some degree of halos around a point source of light at night is completely unacceptable, then consider monofocals or EDOF lenses. Coming to the eye characteristics, if scotopic pupil is small and the patient wants a distance vision predominantly, then choose monofocal or EDOF lenses. If the pupil is large and then the patient wants distance priority, then choose EDOF or apodized multifocals. If it's a near priority, then multifocal IOLs with a higher AD should be chosen. And angle alpha and angle kappa also helps in deciding which IOL the patient should be taken for. So if the patient has a large angle kappa, then avoid lenses with a small optical zone. So use lenses with a larger central optic zone like Panoptix or Symphony, which has 1.1 and 1.6 millimeter optic zone. Multifocals with large central zone or EDOF lenses can be used in such patients. If patient has large angle alpha, it's better to go in for monofocal lenses. Eyes with dry eye, poor corneal topography, subluxated lens, glaucoma and age-related macular degeneration, these patients better to avoid diffractive multifocals and to some extent EDOF lenses as well. So before surgery, it is better to investigate the patients for dry eye, macular disease, potential visual acuity, corneal topography, and accurate biometry, and good IOL power calculation is mandatory for such patients. To exchange of information regarding the side effects of the multifocals, diffractive multifocals, and EDOF lenses like halos, glare, and starburst are necessary to get a satisfied patients. Finally, it's a balance between occasional use of glasses or the tolerance to this dysphotopsia that decides which IOL the patient should go in for. Thank you.
Thank you, Dr. Vijay. I just wanted you to tell me, how do you choose between EDOF, meaning VVT, and trifocal when you have a patient who can afford both in your practice?
So if the patients really insist on, he is more into reading, especially the mobile and the text reading, then we would prefer trifocal IOLs over VVT. But if the patient is more into computer use and tablet use, then probably we would go. And he's more into night driving, then VVT would be better.
And probably if he also knows that sometimes he may need to carry a small reading aid. Any questions from the audience? If no, then thank you, Vijay.